Well, hello, folks. It's wonderful to see everybody here. I'm Tony Capone, a pediatric retina specialist and the president of the foundation. And this is Matt Tracy.
Hi, I work for Tony.
No, not hardly, not hardly. We work very much together. And welcome to the Q&A section. And we'll try to A the Qs here. And and Luis, I think, are we going to start with some of the folks who are online or try to go to the audience first?
Yeah, that's a good question. So we do have one question online that I will start with, and then I do have questions that have come in from those who registered, and we'll go through some of those as well. And those of you in here in the audience and those online, just raise your hand if you have a question, and we'll entertain those as well. Okay. So let's start with Liz online says, is it normal for a young adult with fever to already have retinal tears? What are the best treatments, and are there any preventative procedures?
Okay, that's three questions.
Well, but she put it in one.
All right. Actually, I'm gonna pick up off the tail of what Dr. Minton was talking about, the question about genetic testing, and then we'll lead into this. We'll make it four questions. We have not yet identified all. There are folks who come in and they clearly have familial exudative vitreoretinopathy, acronym FEVR, right? On a clinical basis, unequivocally. But on genetic testing, not all of them will come back genetic positive, right? So that doesn't mean they don't have the condition. It does mean we haven't figured out all the genes yet, right? So if we send off the genetic testing and it comes back positive, right, then there are a number of genes. They vary with regard to how severe the condition is. And we know then to go ahead and test other family members, right? Because folks will want to know if they have siblings, if they carry the gene or if they don't, because you can have fever and have completely normal vision, right? So there's a range of how folks can be affected when they carry the gene. So not everyone who carries the gene has vision loss, right? So not uncommonly, for example, a child will come in and the parents aren't aware that they carry the gene because they're normally sighted, but it happens that the child was more severely affected by happenstance. On to the question. The first one, I'll take the first one. I'm going to hand off to Matt for the other ones. It's kind of interesting, the question of fever and retinal tears. In fever, one of the classic features is that the retina doesn't form a normal kind of pattern of vessels in the retina. Some of the retina doesn't have vessels, and scar tissue grows, not that much different from retinopathy of prematurity. And scar tissue has a life history in the body. Everywhere that scar tissue grows, its job, it thinks, is to close a wound. So first it grows and then it contracts. And when it does that in the retina, it's like taking a piece of film from a camera and just pinching it and distorting it. That's what the scar tissue does, or grabbing my pant leg and contracting it like that. The retina folds like that. So folks who have fever get tractional retinal detachments, right? Retinal detachments can also occur when there are tears in the retina. That's another kind of retinal detachment. It's got a long mumbo jumbo, medical name. It's called rhegmatogenous retinal detachment, but that means retinal detachment due to a tear. Interestingly, in the United States, fever almost universally causes only traction retinal detachments. There are some places in the world, and this is like not all genetic types of fever are the same. So in Asia, they get a combination of detachments due to traction and to retinal tears. So the short answer to the question is no. In the US, unless someone is of Asian origin or Asian extraction, it's not common to have retinal tears. So if I saw a patient in the office that had retinal tears, I would wonder, do they have another condition that can predispose to retinal tears? So for example, are they very nearsighted? And folks who are very nearsighted can have retinal changes that predispose to retinal tears. And so if you ask question number 2 of the 3, Matt's going to take it.
Question number 2, what are the best treatments?
Well, so Tony said most of the things that I was going to say. I do think, just kind of pulling on that thread a little bit, though, some of the folks in Asia, particularly in Japan, they've suggested a different classification system for fever, which includes things about tears versus holes. And we spend a tremendous amount of time talking about the difference, but they basically are the same in a way, right? Which is that there's a defect within the retinal tissue that can predispose you to a detachment. In the Japanese literature, they show that these tears are much more likely to occur in an area of the retina where there are still blood vessels. And it's because the vitreous is the jelly inside the eye is still attached in an abnormal way. So that interaction between the retinal surface itself and the jelly is not quite normal. And then there are holes. And in the scenario like Dr. Capone was talking about, where the blood vessels in, let's say, retinopathy of prematurity don't make it all the way to the end of the retina, the same thing happens in fever. And over time, you can develop these thin areas and you develop a hole just because there's not a blood supply, and so the tissue becomes kind of atrophic and weak. And you would approach those differently. So this is a long-winded answer of getting to how you would approach it. So you may consider using a prophylactic laser to ablate that area of the retina before it develops a hole or a tear. If there is a hole that develops and you're lucky enough to catch it before a retinal detachment happens, you could consider lasering around that, or using a freezing treatment called cryotherapy to put around that. Sometimes you can't do that, though, depending on where the tear is, and you may need to use an external device to sort of support that as well, which would be something like a scleral buckle. So there are a lot of different options.
So it may not be obvious to folks why a tear or a hole in the retina can lead to a detachment. So if you already know this, then just be patient. But so the eye is a sphere, right? And the retina lines the inside of the eye wall like film. And the center of the eye is filled with a gel. And you may remember from high school bio, it's got a silly name, right? Vitreous humor, right? If you get a tear or a hole in the retina, the gel, which is semi-liquid, kind of like an uncooked egg white, can track through that hole and it blisters that layer of retina off of its foundation, right? So that's all a retinal attachment is. It's a blistering of the retina. So not unlike a blister in your skin, when fluid tracks through a hole and elevates the retina off its foundation. And once the retina is elevated off its foundation, that part of the retina that's detached doesn't see, right? So if you catch them when there's a hole, but there's no fluid yet, you can weld the retina so that way the fluid can't track through the hole because you've welded around it, right? So you've kind of firewalled around that. So Dr. Trese was talking, you can do that with laser. You can do that with a freeze treatment that does the same thing. Both of those treatments share the common denominator. They cause scarring around the hole, so that way the retina won't detach. So if you see someone early enough, you can kind of cut it off, cut the detachment off at the pass, if you will, right? After there's fluid under the retina, then the treatment is a little bit different. You've got to drain the fluid so that the layer is attached again, and then you can weld. The retina has to be on its foundation for the weld to take, right? So you can catch it before it detaches or after it detaches, you put it back down, and then you can do the weld. Question 3.
Well, question 3 was, are there any preventative procedures?
Asked and answered.
So if I may, yes, I think we did answer that one. Prophylactic laser is a good one in many instances. For the person who asked about LCA, just the amount of change that we've had over the last 10 years regarding available genetic therapies is exploding. And so Luxturna is the treatment for RPE65 mutations in LCA, and that is a wonderful treatment that's helping a lot of people. I just saw last week, though, that there was a new clinical trial for CEP290 LCA, which is the most common form of that disease. So I think it's really exciting. There's a lot changing, and the individuals who are getting gene therapy with Luxturna, as Dr. Mitten mentioned, they're just doing fantastic. So it's a very exciting time when it comes to that. But I do think the genetic testing is important, which kind of leads me into my other thought, which we touched on a moment ago. So the individual who said that they had fever, and do you have to get genetic testing? I would say the answer is yes. You do need to get genetic testing for a number of reasons. if you know the gene that's involved, you may be able to predict the clinical course a little bit. It maybe changes how you follow the patient because you can predict the clinical course, but there are also a couple subset of fever or fever adjacent type diseases that have systemic manifestations. And so you really want to make sure that you do the genetic testing. Now, you won't always get an answer. The answer actually comes from the exam itself, but I do think that genetic testing is really important.
Thank you. And one more from online before we go to those that were submitted is, hi there, is there any cure or future cure for fever?
So I was going to kind of riff off of what Matt was saying, and I will answer the question, but I'm going to start with the background that I think is the answer to the question. I think it's clear from what Matt is saying, we're getting, as we get more and more better understanding of the biologic basis, the genetic basis of disease, you realize that our classifications are just almost kind of specific because they describe a variety of findings, but they're also generalizations because there are a number of genetic abnormalities that can cause those same findings, right? So think back 15, 20 years ago, we talk about cancer. Well, cancer is, everyone in the room knows cancer is not one disease. Cancer is many, many, many hundreds, probably thousands of diseases. Even a specific type of cancer has a number of different variations on the theme. And so, we were talking about LCA, LCA has a variety of genetic abnormalities that can cause it. Leber's congenital amaurosis, right? And so they may share one or two features in common, right? Children are blind at birth, and the retina often looks remarkably normal, or it can have some minor pigmentary change. But then there may be many, many genetic mutations that cause those two features, right? We all call them the same thing, but they're all very, very different. And how you fix them is going to require, require a different genetic fix, right? So the beauty of the kind of where we are today, as opposed to 10 to 15 years ago with regard to genetic therapies, is that we've been able to identify the genetic basis of a lot more diseases, A. And B, we now have the technology to be able to make specific targeted therapies that'll fix that genetic defect. Great. Problem is the good news is it's personalized medicine, which kind of everybody is something that everybody thinks is a holy grail, and it is. But each cure is exceptionally expensive. It takes not millions or tens of millions, but hundreds of millions for any one of these therapies to make it to market. And now the cost is going to come down. We will also figure out ways to fix maybe multiple mutations with a single, therapy. But that's the background as we're talking about this. Any one thing we talk about has a number of different genetic variations that can cause the variety of features that we use to name or that disease clinically based on what the eye looks like when folks walk in the office. So that gets back to the cure for fever. There probably isn't at least in terms of how science is evolving now, going to be not or the cure for fever. There are going to, probably be a variety of different therapeutic options based on what the genetic basis is that has led to the eye having the clinical findings that we call fever. A long answer, but it really gives the depth to, I think, a lot of the questions, and I think helps folks understand how we talk about things, because you can tell that Matt and I have our own vocabulary, right? Every field has its own vocabulary, but we, part of the goal in the Q&A is to make the science accessible so that, the concepts aren't that hard to understand once you translate the language.
Thank you. Another one, and then we'll go to the ones that were submitted. They keep popping up here online. My daughter, who is Asian, has been diagnosed with retinopathy of prematurity with a buckle. Can fever lead to that, or is it a different diagnosis totally? I'm curious if it comes from genetics, if it came from genetics.
So the question, I confess, isn't entirely clear. Retinopathy, a buckle is how you may treat a certain phase of retinopathy of prematurity. So retinopathy with a buckle isn't a diagnosis, but I think the question is retinopathy of prematurity versus fever. So Matt, do you want to take that?
I like this question because it talks about some of the history of ophthalmology too, which I always find interesting. So there was when fever was originally described in the 1960s, it was by Charles Scapins, and the term was that it was retinopathy of prematurity in a full-term infant. And so there are a lot of manifestations of that disease that look very similar. And so the question that the parent is asking there is a great question. Unfortunately, we're lacking a little bit of information regarding some of the risk factors for prematurity, which would help us kind of answer that, and things like family history as well. But a lot of times the diseases, especially in the early phases, they look very similar. Does that sort of answer it?
Yeah, I think so.
Yeah, thank you. And I just want to point out that, today's responses really are, responses for today in general, but we don't claim to offer medical advice. We encourage you to go to your medical team and those that are, that you're taking care of your child or children. But keep asking away. So we'll stay with fever. Some of the questions that were submitted was, does patching help when a fever-affected eye has very low vision?
I would think that patching is huge. We rely very heavily on our pediatric ophthalmology colleagues to help guide us on that. There's a spectrum in terms of how much vision you're going to get back. I have I'm incredibly lucky because I was able to train here as well. And so I was in the operating room with Dr. Capone on many occasions, and he would have me look at an eye and he'd say, "How well do you think they can see?" And I'd look in there and the eye looked very distorted and sort of, not the average. And I'd be like, I don't know, can maybe they see light or a hand moving or something like that? And he would say, "Oh no, they're 2100, 2200. And so, that is in some cases because the parents were patching and really made that eye work out, so to speak, so that they could get the best possible vision. So I'm a big fan of patching.
I'm thinking we should hand the microphone to Dr. Drosty. Do you want to answer this question, Pat? Yeah, if you would, I'll bring it to you. Here you go.
I'm really glad whoever it was asked that question because it is very important. And I agree totally with what Dr. Matt said. But the thing that's not real clear is how long do you patch? And a lot of times these children, you patch their eye and they really go ballistic and they're upset and so on and so forth. And to tell a mother of a child like that, you patch the child half a day or 5 hours, that's not realistic. So you put the patch on them in the office and you just put the patch on, you see how the child responds. And you move things around, you keep them distracted. And then all of a sudden, they start engaging and that fear factor subsides when they see they can see. So the amount of patching is dependent on the child. And so I usually start maybe 20 minutes, 30 minutes. And I try them in the office because I don't want to send them home with something that's impossible, but I have an idea that they can handle it. And then every time you patch, you're turning those retinal neurons and neurologic neurons back on that were turned off from the detachment or the fever or whatever. So that's my approach.
Before you give that up, a question just popped up. Up until when or what age does the patching work?
Oh, no, that's a huge myth. I want to really tell you that that's a myth. It works at all ages. And if Dr. Matt or Dr. Capone do a retinal reattachment procedure and it comes back and they're 20/50, 20/60, I patch them. I don't patch them forever, but I start with an hour a day and I always get better results from that. So I hope that helps. It's never too late to patch, ever.
And I just want to clarify, Lily asked, did I hear that gene therapy might work to cure fever? Sorry if it was repeated.
No, it's not a repetitive question at all, because I can see how someone might have asked that. So there is not currently, of the hereditary retinal conditions that are in clinical trial, for treatment with a genetic therapy. Fever is not one of them. So, but theoretically, any retinal condition that has a genetic basis is potentially amenable to genetic therapy. So it's the right question. No, there are no clinical trials for genetic therapy for fever. It would be a candidate for that, though,
Okay.
because it has a genetic basis. So actually, it's a clarification. Thank you.
Yeah. No, thank you, Lily. Did we talk about tears? My 21-year-old daughter with fever is starting to have retinal tears.
Tears.
Tears. Oh, tears.
Yeah.
What was I thinking?
Yeah, we hit that
Tears.
one. Yeah.
Tears. Is that concerning? Sorry.
That's the question we spoke to earlier.
Okay.
Okay.
Yeah, that's what I thought. Okay. Let me see what we have here. We have one from our audience here. Are you seeing retinal issues in adults who were preemies with ROP treated with laser? Is that correct? Who asked?
Yeah. So, boy, that's a great question. And short answer, yes. And I say that because the topic of so-called adult ROP, which is a little bit of an oxymoron, right? But of adult ROP, it's a big topic. For a variety of reasons, but not the least of which, premature infant survival has significantly improved. And therefore, folks who were formerly premature growing up are way more common. So it's not just the purview of the pediatric retina specialist anymore. Every retina specialist needs to know about this. Yes, folks who have retinopathy of prematurity in infancy that is effectively treated as they grow, basically they become, the folks that we end up as retina specialists follow for life because they can have problems either from scar tissue or from developing holes or tears in the retina, or the blood vessels can become active again and start to leak fluid or lipid that can get into the center of vision and negatively impact vision in that regard. So yes, adult ROP is a big thing. And again, the kids now, our neonatology colleagues have just done a tremendous job. The amount of ROP that we see now compared to, 10, 15 years ago has remarkably diminished. So they're able to keep the infants alive. But in the past, there was still a lot of what we call in our jargon, prematurity related morbidity, meaning the pulmonary the lung problems, the eye problems, et cetera, et cetera. Now the infants are being kept alive and the amount of morbidity has really diminished. So our neonatology colleagues, total respect, total respect. Matt?
I always like the answer to that question is an interesting one for all of the reasons that you just brought up, right? Our neonatologists are doing a fantastic job, but we're doing a fantastic job too. I mean, the eye issues that we encounter are a lot less, in part because we worked really hard with our neonatologists to make sure we were all on the same page. I do think, though, that there's an era where kids were getting treated with laser, and there's been a shift away from that more recently. And there's we've got three tools, in the upfront when kids are really struggling with retinopathy of prematurity, and laser is still the gold standard in my opinion. There's another intravitreal injection that you can do, an injection that goes inside the eye that can quiet things down. And that has become much more common, in part because the laser itself, which works, is hard to do, and the injections are easier to do. And it's not as hard on the child and all those types of things. What we're finding, though, is that with this shift away from, I guess what I'm getting at is that some people are kind of suggesting that laser is no longer an appropriate treatment. And I really don't feel that's true. I think that laser is an important part of our treatment. We're finding that some of the kids that are treated with the injections that aren't followed, because these kids get bigger, right? You can't really see everything that you used to see. They end up having difficulty with holes, like we were talking about earlier, in the areas of the retina that don't have a blood supply. At a larger rate than the individuals who are lasered. So sometimes what happens is you'll end up treating a child maybe with an injection of medication, and then they end up lasering them anyways down the road. So yeah, it's kind of a long way of saying, there's multiple different ways to treat things up front. You don't necessarily have, but nothing is without risk.
So Matt's 100% right. So what the injections do is it stops the disease from going, 60 miles an hour, right? And it may even stop it. And that's just part of what needs to happen. The next thing that needs to happen is either the retinal blood vessels need to finish growing, or you need to laser that area to eliminate, the risk of having a retina without blood vessels, because a retina without blood vessels, A, is vulnerable to the disease reactivating, right? Or B, retina that doesn't have blood vessels is more prone to develop the kind of holes we were talking about, right? So you stop the ROP, but you then leave that eye at risk for holes, particularly as they get older. And sometimes, typically you don't get detachments from holes in the retina until folks are honestly in their 30s or 40s. But a former premature can get detachments in their teens, from having a broad area of the retina that doesn't have full blood vessel development because holes form more easily in a retina that doesn't have blood vessels. So, and that's another topic of, we still call that adult ROP, but it's really adolescent ROP. Yeah. And they are harder to fix. They can be more subtle. The detachment happens so slowly that I had a super smart kid had ROP, spontaneously regressed. He was never treated, right? Just got better on its own. Didn't lead to detachments, but only one eye ended up being good. The other eye had, severe lazy eye, or amblyopia, the correct term, and developed, had a hole in the retina, had this retinal detachment that moved so slowly. Smart kid, valedictorian in his class, right? So this is not like being smart didn't protect him. And he didn't come in until his center of vision was literally split by the attachment, right? And why, right? Why did that happen? Because it happened so insidiously. He kind of day to day didn't notice any difference. Probably took a couple years, for that to happen. So there's still very, very serious consequences from ROP that can happen throughout life. That's why we follow them for life. And yes, you get less nearsightedness with the treatment with injections. One of the consequences of doing the laser or the freeze is the eye ends up a little bit more nearsighted. But for me, when I say that word in block letters, underlined is the word sighted. Near, far, as long as that child is sighted, everything else can be addressed. So we took a sidebar there, but.
Thank you. That's all right. Here's a question. Could I take part in a clinical study and is it safe? Could you maybe talk about how families should think about clinical trials?
Yeah, this is a great topic, and I'm sure Matt will have more to say as well. So let's talk a little bit briefly high level. So clinical trials are done in 3 phases, right? Phase 1, phase 2, phase 3. Phase 1 is the safety phase. In a way, well, absolutely, the most important thing is safety. Kind of in a way, you don't so much care about whether or not the drug works, because safety is the mission of the phase 1 clinical trial. But after you find out if it's safe, you kind of care how it works. So you always look for, in our jargon, we say you're looking for signal, right? Looking to see that the drug has worked in addition to being interested in whether or not it was safe, right? After you know it's safe, you go to phase 2. And then typically you're trying a range of doses that may be effective in a slightly larger population, right? And then now, since it's a larger population, that'll be further evidence that it's safe because some, side effects, we'll call them adverse consequences in my jargon, side effects may only happen 1 in 200. So if you only did a phase 1 trial with 20 folks, you may not catch that 1 in 200 side effect, right? So you increase the number of folks in the trial and you start to give the range of doses that are kind of at the top and the bottom of where you think you might find the final drug to be effective. And then if it's safe, and now if you have an effect, in phase 2, then you go to phase 3, kind of hone in on the 1, maybe 2 doses, much bigger population. And then if you get through phase 3, the drug works and it's still safe, then then the FDA will generally say, it's showtime. We also talk about a phase 4 trial, and phase 4 for us is how does that drug work once it gets in the wild, i.e., after it's out of the clinical trial, which has really strict guardrails, what the vision is, what the patient has to have to get in the trial, what they can't have to get in the trial, et cetera, et cetera. Then we're interested in how things go when the drug is actually being used by physicians in day-to-day care of folks. So for those of you who didn't know the phases of clinical trial, I thought that might be instructive. The so this comes up a lot of times when folks will say, well, there's this new thing, I'll say snake oil for, you can fill in the blank, that's been suggested for this, I'm going to do it. And what do you think of it, Dr. Capone? And let's say it's a natural treatment, right? So I don't pretend to know everything about anything, right? So I'm not going to say that something absolutely doesn't work, but I am a man of scientific rigor. And so if I came up with a new drug tomorrow, we would have to go through this phase 1, 2, 3 scenario before we approve for a clinical trial. So anything that folks are going to do, so for a while, folks were just taking stem cells and injecting them into the eye, right? That didn't turn out well for the patients for whom that was done, right? But that wasn't done within the confines of a clinical trial, and bad things can happen. So clinical trials are specifically designed to ensure the safety of the patient. That's the most important thing. Whether the drug that is being tested works is secondary. Safety is job one. So my short answer is, and I don't usually give short answers, as you can tell. My short answer is yes, clinical trials, are safe, or if there are risks, they are fully disclosed on the front end, right? So another sidebar, a new cancer therapy, the drug may have some risks to it, but then that's a risk benefit calculus, right? Because the problem that you're treating, probably has greater risks than the treatment being suggested. Yeah. Matt, anything?
Yeah, so I think that that idea of so you beautifully went through the clinical trials. The decision to decide to participate in a clinical trial is an interesting one, though. And I have many patients who say, hey, you know what, this eye doesn't work very well. You can just take it and do whatever you want to it, right? And we can't do that. That's not within the confines of the clinical trial. It's not safe. It's not how we want to do it. But if that person, for example, is seeing well out of their other eye, they have a lot to lose there too, right? So I bring that up because the way that we design the clinical trials and think about designing clinical trials is for the patient's safety. And so it may seem like it's a very slow process, and even though you would love to participate in a clinical trial, you really have to hit certain metrics in order to be included. And if you're interested in it, talking with your doctor about it is the way to go.
Thank you. We have a question from here, our audience. We have 3 generations with best 1 disease, all exhibited vision loss at different ages. Our son at 5 years old. Is it totally random how it presents? Number 1. And 2, are there best clinical trials with any success? We have 3 generations with, who asked that question, if you don't mind? Here. You asked. You probably could do a better job than me.
That's pretty clear.
Oh, okay.
Yeah, I think we got it.
Hi. My husband is the middle generation with best 1, and our son Sam, who's the one you can hear yelling in the other room. He's a patient of Dr. Drenzer's, and then Darren's mom also has it. Sam, from what Dr. Drenzer has explained, was very young, and he is at the point where he does get Lucentis shots, and was just wondering, because then Darren has very little at vision loss, and Dr. Drenzer says that his is kind of wacky, as she says, and then his mom was diagnosed in her 20s. So I just, it seems so random, and I'm sure many of these are, or maybe it's not, and I missed something, but then also looking at what, it's hard to find if there's any clinical trial. I know there's some potential gene therapies, but just wanted to know from another eye disease, what your thoughts were. Thank you.
Yeah, thank you for being here, and thank you for the question. I also, I'm going to tease Dr. Drenzer for using the term wacky. Best disease is a autosomal dominant, so it makes sense that it would be in every generation. And then for the rest of the group here, you may already know this, but oftentimes we think of it as having a couple different phases. We just in Best disease, when you look in there, it almost looks like there's a yolk in the center, right in the middle of the vision. And over time, that yolk will sometimes, we call it scramble, right? Because it looks like an egg and then it scrambles and then it will sometimes collapse or leave an area of lucency underneath the retina. When that happens, it can predispose you to developing these new bad blood vessels that end up growing underneath the retina, which some patients require injections for. It's a one gene, it's the best one gene that causes Best disease. But going back to what we said before, we think about a mutation as just, when we classically learn about mutations, maybe you think about a point mutation where you have one change to that gene, but in reality, maybe you got 3 of them, or maybe you got 10 of them, or whatever it happens to be, and that can result in different manifestations of the disease. So there's a genotype, the gene, and then there's a phenotype, and if you have, it makes sense that if you have a more severe genetic mutation, you can end up with a more severe disease. Does that make sense?
Yeah.
Okay. Anything?
Yep. So Matt, meandering onto a topic, I'm going to put you guys, this is a little mini medical school today. Another medical term I'm going to use is we talk about, so these, in a given family, we talked about different genes with for a given disease can impact with varying severity, right? But when we know it's the same gene in the same family over and over again, right? It's a bit of a mystery why they don't all look alike, right? And this happens in fever as well. Patients can be totally normal sighted. They won't have any blood vessels in the periphery, but their macula, center of vision, is totally normal. And then their child may end up with complex retinal detachment in both eyes. So there's a concept of phenotypic variability, right? And that's basically what Matt was alluding to. And that is that the same gene can have phenotype genotype is what the genetic issue is, right? Phenotype is how it manifests itself, what it looks like, right? So why would the same gene look differently? Well, we know that it can happen. What we don't really know is the why. I'll just share with you my way of thinking, and I'm not sure that it's right. But we see this in a number of other diseases, and that is that none of our genes live in isolation in our body, right? And so the likelihood, in my opinion, is high that apart from the kind of thing that Matt's talking about, like in some folks, the egg may scramble just or scotch away from the center of vision, another person right in the middle. That's not really phenotypic variability. That's like luck almost, right? 50 microns isn't really phenotypic variability, but a total detachment, no detachment at all, that's meaningful phenotypic variability. So my notion of it is that there are many gene interactions. And the same way we haven't identified all the genes, for example, that cause fever, we are nowhere near. We still tend to think in a one gene, one disease kind of way. I guarantee you that's as overly simplistic as thinking cancer is one disease or fever or RP is one disease, right? Now you heard several conversations, RP 65, where all of these, different subtypes of RP. I think phenotypic variability is likely genetic, interactions that we are not sophisticated enough yet to completely understand.
Too.
Yep,
I mean, there's a new field of that. I mean, it's not that new anymore, but there's a new concept called epigenetics where your genes are methylated, and you can think about that as like a light switch, sort of, where it kind of turns it on and off. And so we are still learning a ton about that. So you could have different epigenetics associated with a Best mutation, which would result in a different sort of clinical phenotype or the way that it looks. But it's a great question. I think that was a long way of saying we don't really know the answer.
I could answer that.
Do you know of any clinical going on already? Yeah.
So, admittedly, not my specific wheelhouse. Now within pediatric retina, which is already a sub specialty, right? Because retina subspecialty of ophthalmology, there are some pediatric retina specialists who are specializing in genetic therapies, right? So I am aware of at least, this will give you a chance to maybe get online. At Cincinnati Eye Institute, Robert Sisk is engaged in a clinical trial for genetic treatment of Best disease. And feel free to use my name if you decide to go down.
Or you can use Dr. Drunzer's name. She's not here. We received a question on Stickler syndrome.
Thanks, Ken.
Are we getting any closer to something on the genetic side that could actually change the disease?
I think not that I'm aware of. Short answer from my perspective is no. Matt?
Well, I think my answer is no also, but I do want to tell you that we're working on it. So we have started utilizing the biobank, which PRRF sponsors. We've started compiling many of our Stickler's patients and to start to look at some of the collagenopathies that may be associated with it. So I guess that wasn't very clear. So there are patients with a well-known Stickler's disease, which has the genetic mutation. And over the last several years, we've started to identify, not surprisingly, subtypes of Stickler syndrome, right? So there's type 1, type 2. It actually goes all the way up to 9, I think is the last that I heard. And so, but vitreoretinal degenerations like that are something that we know exist, but a lot of them don't have names. So Stickler's is the most famous. There's Wagner's as well as several others, but you look in there and you know it's not totally a normal looking eye, but it doesn't necessarily have a name. So we have started to use the biobank here to get more information, start giving these names so that we can start to understand how to treat them. We're in the very early phases of that, but I think it's an exciting area of the biobank and PRRF that we're able to hopefully expand into in the not too distant future.
Yeah, that's great, Matt. That's a great segue. So a couple of quick things about the biobank in a place like this. The reason why a biobank was important for us is that pediatric vitreoretinal diseases are rare. I think lots of you know you're probably not just the only person on your block, maybe your zip code, depending on how rare it is, maybe the only one in your state. So, and unlike a lot of other medical conditions where they sort of have classic features that 75% of patients, will manifest, many pediatric retinal diseases have rare manifestations, meaning they don't look very much alike necessarily, right? So you got a double rare manifestations of rare diseases. So that's where the genetics are really, really critical. And that's why we did such a big push to establish, a biobank here, and why we're so, constantly reminding each other and ourselves to submit samples, because that's the ground truth in terms of the biologic basis of the disease, right? So, and that's where I think cure starts there. I will say one other short sidebar. We have one of the real challenges there are several challenges with Stickler disease, but one of them is when retinal detachment repair doesn't work, the most common reason is that scar tissue forms inside the eye. And it's a misguided healing response. So go back to my prior comments about scar tissue, right? So there are these cells in the eye that usually sit beneath the rods and the cones that are important for their support and their survival. When you get a tear in the retina, these pigmented cells under the retina, fluid gets in that tear, but also these pigmented cells get out. And these pigmented cells, when they get out, change their behavior, and they start to behave like scar cells. And remember, scar cells have a life history. They grow and they contract. So once scar grows on the surface of the retina and it contracts, then that retinal detachment may fail, right? It's got another long mumbo jumbo medical name. It's called proliferative vitreoretinopathy. We abbreviate it PVR. The reason I'm saying that is the Stickler kids, so risk factors for PVR are youth, trauma, and male. And so, the youth part is important here. They're usually not traumatic detachments, although they can happen with otherwise trivial trauma. But the scar tissue is really a problem for the children with Sticklers. So in the last, it's probably longer than I think it is, maybe 10 methotrexate from beginnings. So we've started to use an old cancer drug called methotrexate in the eye. Some folks use it during the surgery in the infusion. We use when we do the surgery, we make 3 holes in the eye, and so you need a water line to keep the water balloon that is the eye inflated while you're working in it, right? So you can put the methotrexate in to infuse during the case. You can inject it after the case, and then we often do 12 injections over several weeks after that. And the methotrexate reduces scar formation. So therefore, if that retina was attached at the end of the surgical case, you're much more likely that it's going to stay that way if you use methotrexate particularly in a stickler's child, because you stopped the formation of scar tissue and its contraction. So genetic therapies haven't really advanced to date in sticklers while, the work is going on, but our surgical management of it has meaningfully advanced in the last 10 years with the advent of methotrexate as an anti-scarring treatment.
Thank you. Another question, ROP-related vision loss. Are there treatments today that could improve vision?
I don't know. This is it. Actually, the expert in the room on this is, again, Dr. Droste, who has done more with ROP-related vision loss by far than I. Pat, do you want to take that?
How I got involved with this group 40 years ago, as I was at William Bowman, I was working with Dr. Trese. I was in charge of the clinic at that time. And doctor was doing a lot of very sophisticated, not previously performed type retinal procedures to save the retinas of these babies. And most of the time it involved removing the crystalline lens to reattach the retina. So we would see him in clinic, and I remember sitting right next to him one time, and he said, "Well, Pat, the retina's on. Now it's your job to make the child see. And there is how it all started. And there are variable degrees of vision in these children, as you know. But one thing we've learned from the RPE65 gene, the Luxturna gene, gene therapy, is that the answer isn't all in functional, visual acuity. It isn't the 20/20 number or the 10/20 number. It's how do they see? How do they go from here to there? How do they go out that door or in that door? And they develop what they called a maze. So the children that got the RPE65 Luxturna in that clinical trial, they didn't just measure their vision, they made them negotiate the maze. And those children that got the treatment could negotiate that maze much faster than the ones that didn't. And that's why Dr. Trese says it's been a great success, because these people are now functional. In ROP, the same thing. We could never all get the vision, but we wanted them to function. So we developed the visual function battery to assess that, and glasses and patching and glasses and patching. And when the eyes get crooked, we straighten them, because crooked eyes that are straight or have a common motor alignment have a much better symbiosis, so to speak, with the brain than when they're skewed. So that's it. Glasses, patching, glasses and patching, and strabismus surgery. Did I answer that question? I hope.
Before you give that up, because this might be for you as well, we received a few questions around prostheses. I don't know who that might be, or if any be.
Okay, scleral shell prostheses. I'm really happy you brought that up, because a lot of times the eyes in these children don't see well, and they don't look great, but they're very valuable to the patient. They're their eyes. And so we don't recommend enucleation or removal of that eye unless it's blind and painful. If it's painful, that changes everything. But if it's just blind, it's still their eye. So what we do is we put a prosthetic shell over the eye so that it looks, quote, normal. The problem is the cornea is still intact. The cornea has lots of nerve endings on it. And when you put the shell on, it stimulates those nerves, and the children don't like it because it doesn't feel good or it hurts. And we try different things like ointments and things to get them into it, but most of the time it fails. So if there's a live or intact cornea, the chance of it working is not so good. So before we go through the effort of getting a prosthesis made, which is very difficult and time consuming and expensive, we'll put a plastic one in just to see if they can tolerate the shell. And if they can tolerate the shell, hey, let's roll, But if they won't and they're constantly pulling it out, then we just say, this is the way God wants it. It's the way he wants it or she wants it. But to them, they still have their eye.
How about the facial or socket bone growth? Does it affect that? If they don't do the...
No, That is not a reason to do an implant,
Okay.
right? That is not a reason.
Perfect.
Thank you, Pat. So for a little history lesson here. So, Dr. Trese is well recognized for being a surgical innovator. Not as well recognized is what Pat just shared with you. After we put the retina, reattach the retina, it really falls to the parents and the pediatric ophthalmologist to do everything they can to optimize the vision that we get from that procedure. And Pat worked at Mike Tracy's side for really the duration of his career, and was a key participant in a lot of the literature that was generated from all of those surgeries. So huge contribution. Yep. And on this, the spirit of the scleral shell question, there is a literature on using scleral shells to help the socket grow. So the eyeball has a relationship with the tissues around it, right? Behind the eye sits in a socket which is shaped like an ice cream cone, and the back part of that cone is filled with fat. And so the eyeball and muscles and arteries and nerves, but largely for the purposes of aesthetics, the fat. And so the eyeball, the fat, and then the bony socket all have a relationship together. And so when a child, an infant, for example, has something that compromises the growth of the eye, then commonly there'll also be a difference in the growth of the socket. As they get older, the difference is less apparent. But that's all the pictures of little babies where their eyes look huge. It's because the proportion of the eye to the face is much different in infancy than it is in adulthood. So they tend to outgrow, if you will, the minor deformity of that. But there is a school of using conformers to improve the growth, because you can use expanding conformers to make the socket grow more fully. The spirit of that question, because I read the rest of it, is, and so if the socket grows more fully, is that better somehow in terms of visual prognosis, or is the eye the socket more amenable to a whole eye transplant or things of that nature? There is no functional impact on vision of that. It's an aesthetic, and I'm not trivializing the aesthetics; they're important, but from a vision function perspective, there's no advantage to socket expansion. Matt.
I also was able to read those questions, and I think that there's a couple other things to consider here too. So I fully agree with Dr. Drosty. We oftentimes work very hard to get some vision in the eyes, and to cover it up with a prosthesis is, it's not good for anybody. However, there are some scenarios where facial asymmetry really is a problem. For example, you have a persistent fetal vasculature syndrome where the eyeball is actually the size of the head of a pin or something like that. Moving on to serial conformers to expand the orbit, I think does help a lot with facial asymmetry. There's even a little bit of literature about in individuals who have bilateral, small eyes or tisicle eyes, meaning that the eyes become sort of shrunken and disorganized, that if that happens at a young enough age, it'll affect your maxillary sinus enough that it can affect your ability to swallow. So there's a lot of different things that you need to consider when you're deciding to put a conformer, which is the name for the little plastic piece that Dr. Drosty was talking about, in place. The most important thing to us, though, is whether or not you're able to see anything, right? And so I've had many parents who are very concerned about the facial asymmetry, and they have talked about putting a conformer in, but that's their eye, right? And so you don't want to cover things up, because that connection between the eyeball and the brain will then become compromised. These conformers, there are a couple of companies out now that are actually trying to make clear conformers with lenses in them as well. So I think that that's still a little bit off right now, but I have a couple of patients who are exploring those options also.
Thank you. This one came from our audience here, and it may be a question for our panel, but I'm going to let you guys answer as well if you have. How are you using AI for both children and adults to help with vision problems?
Well, so the brief answer here is that when I put anything about what we do into AI, it has no idea what we're talking about. So I think we're okay on job security for that one.
For now. No, nothing to add. We're really not using it meaningfully in pediatric retina.
Okay. And we are headed to lunch, but I do want to shout out that Lily said, I'm glad I'm here to hear different opinions and recent updates. Our doctor is great, but this is fantastic with questions from others that I hadn't considered. My 8-year-old son will start patching. On that note, there is a podcast on patching. So listen to our, go to our website and prrf.org and check out the podcast on patching. I think you'll enjoy that. Any other questions? Anything anyone have a question here? Okay. Yeah, because our audience online.
This is absolutely fantastic, but I come from blindness. And so as I'm listening and the goal is to get the patient to see, and my world is to get that person to function. So how do you, when you're working with your patient, when do you know it's time to say it's about functioning and not necessarily visually?
So I'll give my answer. I'm sure Matt has his own. For me, it's always about function. And visual function is just one aspect. And obviously, as vision declines, one doesn't have to go all the way to blindness before there are function challenges. So it's part of the spectrum. And for me, it's included in what I do routinely. Matt, I know Matt has a specific interest in that end of the spectrum.
In part because I work with Charlene on this topic quite a bit. It's a really hard question, actually. And it's a hard question because people need to be ready, as we've talked about many times. So when we work really, really hard to get you seeing as best that we can. And sometimes that means you're seeing light, and sometimes it means you can see a hand, or sometimes you're able to drive a car or read, and those are wonderful scenarios. But there's a period of time where you're really fighting hard to get as much vision as you can. And if you start introducing concepts about, I want to get you functioning, people sometimes feel like you're giving up on them. And that's not what we're trying to do. What we're trying to do is use a multifaceted approach to get you to be as functional, independent, and to living a happy life. That's the idea. But sometimes people just aren't ready for it. So I think about it a lot like smoking cessation. So we say to our patients all the time, "Oh, you're still smoking. Have you heard it's bad for you?" "Oh, I noticed that you're holding the wall to walk down. Would you like to talk to someone about getting a cane, or would you like to talk about orientation, mobility training, those types of things?" And oftentimes the answer is no, but it's always in the back of our mind, and we bring it up a lot. But when you're ready, we know the right people to send you to.